Good afternoon, everyone. Today, I am here to present my seminar on the topic of the non-verbal behavior. Uh, in the previous series, we have studied about the dynamic structure of the interview. Today, we will study. Today, we will discuss about the non-verbal behavior. And my moderator is Dr. Sumit Mehta sir. Non-verbal cues play an obvious and critical role at way stations such as engagement, data gathering, and understanding the person. We have studied about the engagement and data gathering in previous two seminars. Indirect non-verbal behavior indirectly impacts assessment processes such as the diagnosis, enhance our ability to communicate. Basic terminology of non-verbal behavior are non-verbal behavior as general category of all behaviors is displayed by an individual other than the actual content of his or her speech. We can split the broad category of non-verbal behavior into two general subcategories, that is non-verbal communications and non-verbal activities. Non-verbal communications, also known as the emblems. For example, during a cricket match or a football match, umpire or referee uses a complex set of emblems to communicate with the various decisions to the players of the team or penalties and that the players have committed. So this is an example of an emblem. Uh, for example, the OK sign, which indicates that one approves of the current situation or situation in America, is viewed as somewhat vulgar in Brazil, and in France simply it means zero. So the emblems can mean different in cross-cultural communication. Non-verbal activities are hand gesturing, facial expressions, and even more directed acts such as chain smoking cigarettes all represent non-verbal activities. A non-verbal activity such as fidgeting the pen may indeed be usefully interpreted by the observer as having a meaning. Perhaps it may indicate an underlying anxiety. However, this interpretation can be wrong, and in short, non-verbal activities may have numerous meanings. Ekman and Friesen categorize non-verbal activities into four classes, that is, illustrators, regulators, adapters, and affective displays. Illustrators are hand gestures used to complement, expand, and clarify spoken language. Regulators are facial movements, hand gestures, and body movements that serve to control, adjust, and sustain the flow of conversation, like eye contacts and head nods during the interview to sustain the flow of the conversation. Adapters are behaviors that are performed for the most part without the conscious intention to allow oneself to feel more comfortable, like stroking the face, picking at one's nails, rolling a pen, or changing postures. Affective displays are facial movements that tend to spontaneously occur when a human is feeling a particular emotion, like uh, furrowing of the brow, tensing the jaw, and intense staring during a period of agitation. Cautionary note on interpreting non-verbal behaviors is it is unwise to begin assuming that one knows exactly what any given non-verbal activity means. For example, a patient is experiencing severe marital discord because she is playing with her wedding band. Such interpretation of non-verbal activities are invaluable if kept in perspective. However, the clinician needs to think about other possible causes of stated activity. For instance, this patient may be playing with her wedding band because she is intimidated by the interviewer, and she releases her anxiety by playing with the objects in her hand. Normally, she rolls a pencil back and forth, but due to pencil is not available, so she twists her knife instead of the pencil. Some core fields of study in non-verbal behaviors. Proxemics. Proxemics deals with the manner in which people are affected by distances set between themselves and objects in the environment, including other people. By observing the patient's use of space, the clinician may even uncover certain diagnostic cues. Hall delineated four interpersonal distances. One of them is intimate distance, another is personal, third is social, and fourth is public distance. Intimate distance is of 0 to 18 inches. Within this distance, primary sensory channels would be tactile and olfactory. For example, while people hug each other or cuddle each other, people feel at home with specific scents. They associate it with the lovers and children. Thermal sensations also play a role at this distance. Visual cues, on the other hand, are diminished. Personal distance is of 1 to 4 feet. Kinesthetic cues continue to be used, and the olfactory and thermal sensation slowly the olfactory and thermal sensation diminish, and sense of sight begins to assume more importance. As the distance increases, uh, 4 to 12 feet is considered as a social distance. A face-to-face social interaction, mostly the interview, occur within this distance. And at this distance, voice and eyes play a major role instead of olfactory and thermal sensation. Public distance, which is more than 12 feet, vision and audition remain the main challenge of communication, and people tend to lose their individuality and perceive them as a part of their community. A respect for these and why these spaces are or distances are important, because while interviewing the patient, depending upon the type of patient we are interviewing, we need to respect the spaces, uh, uh, the distance between the interview and patient. Kinesics is an another term. It is the study of body in movement. It includes gestures, movement of body, limbs, hands, head, feet, legs, facial expression, eye behavior, and posture. Dynamic qualities such as speed, acceleration, complexity, symmetry of body, and facial expression may have a great impact on non-verbal behaviors are interpreted. Therefore, kinesics is important. Another term is paralanguage, which focuses on how words are delivered. It may include elements such as tone of voice, loudness of voice, pitch of voice, rhythm, and fluency of speech. हम कितनी बार अपने दोस्तों से या घर वालों से बैठते हैं तो हमको उनकी बातें बुरी नहीं लगती, हमें लगता है कि जिस टोन में उन्होंने बात की, तो दैट इज द पैरा लैंग्वेज की टोन आपकी वर्ड्स पे अपनी जैसे immediacy describes the sensation that one is the immediate presence of another person, and the positive or negative feelings of warmth, closeness, involvement, and acceptance experienced in that presence as created and or reflected by their non-verbal behavior. Immediacy results from the interface of factors from all three of our core elements, which we have studied in the previous slides. Clinical application of non-verbal behavior, non-verbal hints of classic psychiatric diagnosis. For example, in a schizophrenia patient has a tendency for gaze aversion, flattening of effect with decreased movement of eyebrows. Patient postures are slumped and have a tendency to lean away from the interview mainly because of the paranoia. In agitated depression, patients demonstrate puzzled expression, grimacing, frowning, gaze aversion, agitated movements, and crouched posture. In withdrawn depression, some increase in gaze, slowed movement, self-touching, emotionally blank expression, and backward lean away from the interviewer is present. Non-verbal hints of specific personality diagnosis. This is a scenario in which an adolescent girl with a head of curly, light, reddish hair uh, enters the room, and interviewer was sitting on a couch in a group activity room. Patient entered the room and promptly plunked down beside the clinician. First, she leaned towards him with her right arm straddling the back of the couch behind his shoulder, but she quickly withdrew the arm. Her final perch was with her right knee up on the couch, resting a few inches from the clinician's body. In a proxemic sense, she had positioned herself well within the personal distance zone and actually very close to being with the clinician's intimate zone. Her speech was bright and snappy, percolating from a face rich with expressions and playful eyes. All this activity occurred in a matter of seconds, so we can infer that the patient would have histrionic or borderline personality traits. Another example is a woman in her late middle age with graying hair pulled back in a bun. Before the interview, she had to wait for long duration or time in the queue. Initially, the clinician gently apologized for the inconvenience with a warm smile on his face. She made cool eye contact. Her lips did not so much as consider returning his smile. She fluctuated between a baseline of mildly cooperative answer with a reasonably lengthy duration of attention. She tended to lean back in her chair and gradually proceeded to stretch her legs out in front of her towards the interviewer. The movement was ingeniously slow, but as steady as barge pulling to a dock. As usually happens, the dog was gently bucked by her feet pumping against the interviewer, at which point she did not pull away. Instead, the dog recoiled, with the interviewer quickly tucking his feet beneath his chair. So, from this example, her non-verbal activities may be multiply determined, but one possibility well worth exploring would be underlying passive aggressive traits. Some non-verbal indicators of anxiety. During anxiety, sympathetic nervous system gets activated through a variety of physiological adaptations like palpitation, paleness, decreased saliva production, slow bowel and bladder movements, and increasing breathing rate and sweating. Parasympathetic system may try to counterbalance with a discharge of its own sudden urge to urinate and defecate, as people frequently feel before public performances or job interview. If a patient begins a session by immediately requesting the need for the use of the restroom, this may represent a clue to a higher anxiety level than the patient may verbally admit. Displacement activities. It is a type of non-verbal adapter. Body movements that release the underlying tension, like twirling of hairs, picking one's fingernail, biting, etc. Auto contact behavior is another type of non-verbal adapter. Movements involving self-touching. Such behavior may consist of grooming behaviors, defensive covering behaviors, and self-intimacies. Self-intimacies are movements that provide comfort because they are unconsciously mind act of being touched by someone else, like jaw support, chin support, hair clasp, cheek support, temple support, holding own hands, sit with knees pulled up to face, and arms hugging their own legs. These are few examples of self-intimacy. Non-verbal hints of deception. Uh, Micro expressions. Many emotions, when being hidden by a patient, are given away by the presence of minute movements of facial muscles, frequently lasting only for 1 by 15 to 1 by 25th of a second, which may be reflections of the person underlying concealed emotions, be that anger, sadness, or disgust. Patient may be consciously withholding information or that unconscious defense mechanism, such as repression. Such moments of withholding may prove to be critical importance by uncovering any suicidal intent or moments where episode of incest or intimate partner violence are being hidden. Changes. Many researchers consider that changes in below the neck movements may be of the most practical significance for accurately detecting the deception, unless one has been trained. Hand gestures such as illustrators tend to decrease when deceit is underway. Non-verbal adapters such as displacement activities and auto contact seem to be one of the most powerful correlates of deception. Adapters that signal possible deception are touching or partially covering the mouth or touching the nose. Uh, touching, touching the nose while lying has been coined as Pinocchio response. It is believed that the release of catecholamines triggered by the stress of lying results in swelling of nasal tissues, followed by the relief of this itch by a quick scratch. Paralanguage cues that deceit is occurring. For instance, a higher pitched voice has been associated with deception as well as emotions such as fear. On the other hand, low pitches have been associated with the observation that a subject is more relaxed and sociable. Seating arrangements and proxemics. There are this diagram depicts two views. One is the oppositional view and other is the shared world view. In the oppositional view, field of vision overlap very little and patient and the individual feels less comfortable. While on the other hand, shared worldview, two participants are turned slightly away from each other so that subtly facing the same direction but are not maintaining a direct eye contact, which allows good eye contact but also makes it easy to break contact without any awkwardness. Can you explain this? Yes, sir. Sir, this is the patient and this is the clinician and this is the desk and this diagram depicts the angle. So, sir, In the oppositional view, patient and interviewer is sitting face to face, which might make the patient or interviewer uncomfortable. They have to maintain the eye contact most of the time, and while making notes, if interviewer want to break the eye contact, it can be a little more awkward, or patient can think that the interviewer is not uh, solely listening to what the interviewer is saying. Sir, the advantage of this shared worldview is it makes the patient and the interviewer feel that we are seeing the world together, and the interviewer can also break the eye contact in between without creating any awkwardness. That desk should not sit between the clinician and the patient because this places clinician in an authoritarian position, which is more appropriate for chief executive officers, not the therapist. However, the desk can be placed with only a corner protruding between a clinician and the patient, and a wheelchair is preferred because it helps in modulating the immediacy. We talked about the distance, four distances. So if the patient is paranoid, we with the help of the wheelchair, we can go a little backwards, or if an agitated patient, we can lean backwards, uh, so that the patient's immediacy or personal distance is maintained. A responsive zone. This is a zone of effective interpersonal space in which the patient feels comfortable with the immediacy sensations of the interaction. If the clinician moves out of the responsive zone toward the patient, then interviewer risks frightening the patient or creating a sense of discomfort. On the other hand, if the interviewer leaves the responsive zone by moving too far away from the patient, then the movements of the clinician may have very little impact on the patient. Paranoid patient may require a larger space around them in order to feel more comfortable. On the other hand, elderly patients who are very severely or seriously depressed and withdrawn, we might need to sit considerably closer than the normal. Touch remains one of the most powerful means of immediacy behavior. Before touching the patient, we should ask ourselves two questions. What do I want to accomplish by touching this patient? Does the act of touching fit the patient's need for immediacy and non-verbal context of this specific moment in the interview? Because patient may misinterpret touch as an erotic gesture or at a minimum sign as a sign of implied intimacy. Although the clinician may intend the gesture as a sign of caring, a psychotic patient or a patient with histrionic personality may receive considerably distorted message. Non-verbal techniques for engaging guarded or paranoid patient. The paranoid patients generally don't want warmth and intimacy upon the first meeting a stranger. Thus, the golden principle for engaging paranoid patient is, at least in theory, is a simple one that tone down your immediacy behavior in the first meeting with a paranoid or guarded patient. Now we will talk about the impact of clinician gestures and facial expression on the patient. A few notes on the note taking. There exist many good reasons for taking detailed notes. However, on other hand, that much of note taking in initial interviews represents a displacement activity that frequently distracts both the clinician and the patient. We should try taking rough notes, which include bits of information, mostly not in complete sentences. Non-verbal aspects of calming potentially violent patient, which we face mostly at the time of admitting the patient from the emergency room. First of all, recognizing contextual clues of impending violence is very important. Clinicians may inadvertently, with their non-verbal behavior, further escalate an already agitated patient. This cycle represents a violence reciprocal. The signal of impending attack, when recognized in a patient, can quickly alert the clinician that something needs to be altered in the interpersonal diet before a violence reciprocal ensue. The clinician should assess whether the clinical situation indicates that violence is a possibility. We can do with the help of two things. The diagnosis can alert the clinician to an increased likelihood of aggression. Number two is clinician may know that a patient has a history of assaultive behavior in the past. Non-verbal clues of impending violence. There are two signs, that is early warning sign and late warning sign. Although it is very extremely difficult to predict that patient will become violent, but these signs can help us recognize the impending violence. Early warning signs suggest an emerging agitation. One may notice that the patient beginning to speak more quickly with a subtly angry tone of voice. These paralanguage clues may be augmented by a display of sarcastic statements or challenges such as इमरजेंसी में पेशेंट आता है तो बोलता है कि तू अपने आप को बहुत बड़ा डॉक्टर समझ रहा है, तू मुझे इंजेक्शन लगवाएगा। तो ये सारी चीजों से हम इन्फर कर सकते हैं कि वायलेंस हो सकता है। काइनेसिक्स early warning signs could be consist of actual evidence of agitation, pacing, and refusing to sit during the interview. If patients refuse to sit, it is frequently useful to gently request him to sit to return to their position or seat. If patient firmly refuses to sit, then we should not force him and let the patient walk around free. A safety button the clinician should carry or should be near the safety button, or he should know that where is the safety button during the interview. Other kinesics early warning signs include rapid and jerky gesturing, vigorously pointing one's finger at the clinician. Late warning signs can be intention movements, which consist of small gestures that suggest impending action. The intention movement suggesting possible violence includes activities such as clenching of fists, whitening of knuckles, tightly grasping an inanimate object, even a snarling as the lips are pulled back from the teeth. Vacuum gestures are some gestures that represent complete violent action, but they are not actually carried out on the enemy. It includes shaking the fist, assuming a boxing stand, gesturing as if strangling the opponent, pounding of the fist onto the opposite palm. Non-verbal techniques for uh, following non-verbal techniques can be used for calming a potentially violent patient. Number one, avoid engaging in the dominance reciprocal while utilizing some of the submissive behavior. The fear generated by the patient's hostility frequently results in unconscious behaviors that may threaten the patient. Clinician's voice may be raised. At times, actual movements of the clinician speed up. Even frankly, antagonistic remarks may emerge. It is not an exaggeration to say that sometimes clinicians actually precipitate the violence. Some principles that can help the clinician. Clinician should appear calm. Speaking voice of the clinician should appear normal and unhurried. Avoid an excessive display of displacement activities, which may be misinterpreted as aggressive displays by the patient. Eye contact should probably be decreased. Hands should not be raised in any gesture that might signify an intent to attack or defend oneself. Try to keep the hands low and by the side, palm facing the upwards. Uh, Related to nervousness and fear, some clinicians will place their hand behind the back, a gesture that may raise fear in the patient that the interviewer may use a weapon which is even hiding behind. Stoop one shoulder slightly in an effort to appear smaller. Bend knees slightly so as to decrease the height. When near a potentially violent patient, remain in front of the patient because an approach from the behind or from the side may startle an agitated patient. Because in such patients, buffer zone is altered. Some good-hearted clinicians feel a desire to calm the angry patient by touching them. This desire usually goes away after a few unfortunate encounters with feet and face. Arrange the chair so that clinician is closer to the door during the interview. These are my references. Any questions, comments, clarification? How to interact with the parent and patient? Uh, I mentioned about immediacy. I have mentioned in my previous slide. Uh, with a paranoid patient, we need to give him a large space because he's already very paranoid. So if we will go very near to him or make, and we will try to make any contact with him, he will get started or even he's very suspicious that who is this stranger I am meeting him for the first time, is he trying to harm me? So as I mentioned about the four distance initially, uh, uh, that is the point we have to maintain a proper distance from such type of patient. Otherwise, their suspiciousness will increase and they will become more fearful and it will be more difficult for us to establish the rapport. Any other questions? Your views or contributions regarding this because it's a daily, day in, day out uh, issue which we all face. Non-verbal cues, context of violence is one thing, context of psychotic patients is one thing, context of neurosis is another thing. And many encounters, patients will not give you a lot of verbal account, at least initially in expectation. So you have to depend upon your own history and non-verbal. Non-verbal is not something which, as presented, is so easy. You need a lot of time, experience, patterns, then things becomes more easy. Various categories of non-verbal पे जाना ये वाला जो डिस्प्लेसमेंट था तो थोड़ा एक्सप्लेन करना व्हाट इज डिस्प्लेसमेंट एक्टिविटी सर डिस्प्लेसमेंट एक्टिविटीज फॉर एग्जांपल आई एम myself I'm getting anxious so we unconsciously do some activities to release our tension so as an interviewer we do not realize that we ourselves are doing these activities like uh, sometimes it's सर हम अपना like restless हो जाते हैं बहुत सारे तो पेशेंट भी उस चीज से एंशियस हो सकता है या ये देख सकते हैं कि हम क्या कर रहे हैं तो सर दीज आर सम ऑफ द डिस्प्लेसमेंट एक्टिविटीज कि हम अपनी एंजाइटी को कम करने के लिए टेंशन को कम करने के लिए एक्टिविटी अनकॉन्शियसली करते हैं तो हमें तो नहीं पता चलता you can see a lot of patients will have that gaze blank gaze perplexity when patient is brought forcibly is you know, 2 3 guardians are there वहाँ पे आपको अपना डिस्टेंस मेंटेन करना बहुत जरूरी है one of the things which Dr. Ayushi was pointing out that restraining your gestures, not changing your voice tone, not sounding arid in front of psychotic patient with pending psychosis gradually and no scope of heroism. And if patient is getting isolated, is getting aggressive, all your security or immediately escape from that scene because psychotic aggression is a very hostile aggression. I think which was the patient, Rasta was on duty that day. When the patient came in emergency, patient had to be given 18 injections. That patient was subsequently put on ECT. 10, 12 guards, even with the help of 10, 12 guards, don't do anything. So one guard won't be able to manage. So वहाँ पर need to protect yourself and subsequently warm assurance at times might not speaking a lot in front of a patient who is having cycles. That is why when they come to readings, we don't communicate much. Okay, we have confirmed the diagnosis, tell them and don't speak much. Speaking and then they would confuse them even more. If it is in bipolarity, you can and patient is in euphoria, you can have very short dialogue. Whatever what he wants to say, just affirm that and then ask the patient to get it. And later on, when you have time, patient calms down and you can do it. Never say in front of the psychotic patient that we'll be admitting. इसीलिए we use ये हमारे पास रह गए अच्छा नीचे चले जाए अच्छा जांच करा ले
Guardians would want to hear the admit के लिए let the patient go off, send the patient outside, ask them to meet separately. Otherwise, patient might get even more agitated. Like what the patient might need to admit as it, then he might quickly watch. Anxiety, you can always estimate. Patient is sitting in front edge of the chair, and is having an erect posture, fidgeting with fingers, having a rocking movement, uh, uh, very less reaction time. Tension, anxiety, वो इतना anxious होगा. Then the manner in which patient exits will also tell you the anxiety, where patient will get up very quickly, turn very quickly, will maybe hit some things on the way. निकलने के टाइम पे दरवाजे टकरा जाएगा. Will hurry off while going out. तो आपको जाते हुए लगेगा नहीं 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 anxiety लेने जाना है. So that is why the patient enters and the patient exits. That is a very good way of assessing things. कभी that is why in the bedside rounds you can't assess all this. So when you're taking rounds here, you can see how patient would walk. Otherwise, patient is lying in the bed, you won't be able to guess many things. Patients.
In this book, it has been mentioned that shared point view is better than open.
No, so it is always better. Easily, so that corner comes in between. That's kind of an arrangement is always better. Never enter patient. Patient is sitting there like you and me. This is a shared view. So this is never healthy, specifically with watch above. So if you want to keep the watch, always keep on the back side of the patient so that you can look at the time. So it is always healthy. Then you have this 90-degree kind of a. So then patient can have its own time modes. So this kind of an arrangement where corner is coming in between you, patient is the most accurate form of interval. Mankaran, any doubts? You have just joined. So non-verbal, you see furrowed forehead, vertical furrows in depression, hair root sign. Uh, there is very much hold in depression, sweating face. That day, there was an opinion. I was just saying, patient with social anxiety case, arms were very sweaty. Yes. You know? So you can, so again, it's a female patient, you can't touch that. But if it's a lady, you can always see, you can always check the palms while measuring the pulse. And also, a young lady, you can check the pulse and then while she can touch your palm, you can always see it. So that will give you a clue that underlying anxiety is there in the whole context. So that is very, very important. Patient might hide it. Patient might hide that. ये देख नहीं लेंगे. तो कई बार एरिथमिया होता है, पाल्मर रिदमा होता है, और रिदमा से आप अंदाजा लगा लो. And it also depends upon the lot of context in our country. Non-verbal behavior of a Punjabi will be different from Odia, from a South Indian, from a North Indian, from a patient who belongs to a village, to a patient who's brought up in Dehradun, from a son or daughter of a rickshawala to a son or daughter of an entrepreneur. So every context, culture, behavior, background, economic status, education, these things will differ. That is why it is very difficult to generalize. You will not get very set patterns of these. And when you follow them up, you will be only able to have specific idiosyncratic patterns of that patient. So इसीलिए the knowing the culture is very cultural behavior is very important. Here in anyone belongs to mountains? पहाड़ से कोई है आप देखोगे यहाँ elderly females आती हैं. They have different kind of a presentation when they present with anxiety. So the point is the presentations from hilly areas are very different. They come with different expectations to us. They talk about their dailies, their culture and all. They actually, people from this hilly area, they will love if you specifically elderly males, females above 60. If you pat them, touch them, pat their shoulder, you're very happy. Hmm. And how a patient is panting, accessory muscles, how they are using their accessory muscles, that will show you, they are in some kind of distress that is bringing this up. मैं एक सेमिनार में हूँ, कॉल करता हूँ बेटा, ना कॉल करता हूँ. तो वो uh, this will give you a very second clue. You might not examine if it's an outpatient patient and follow. So you can see those accessory muscles, the platysma, the clavicular muscles